Welcome to the Q&A webinar for the Cancer Exercise Specialist Overview. I'm Andrea Leonard, President and founder of the Cancer Exercise Training Institute and 34-year cancer survivor. Thanks for being here. We are going to start off with the Module 1 overview. If you've already signed up for the Cancer Exercise Specialist Advanced Qualification, you have 180 days from the time you purchased it to complete your course. Now, we all know that things happen, unexpected events, good or bad. So if something comes up and you need a little extension, please contact us at 503-502-6776 or email cetiguru@gmail.com. Going back up a step, you also received an MFN or Medical Fitness Network membership with your purchase, and this is good for a one-year membership. You will be contacted directly by them to set up your page on their site, and this is going to be a great opportunity for you to get visibility through social media promotions and additional exposure, and hopefully get some new clients. Your advanced qualification is good for 2 years. As we all know, cancer is changing daily as far as research, surgical procedures, and even survivorship, which is fantastic. So for us as fitness professionals to stay on top of our knowledge base, it is mandatory to do some sort of testing every 2 years. You will be contacted a few months prior to and given the information on how to sign up for your requalification and renewal. Once you have passed your 4th module exam, you will want to contact us. This is what the website looks like on the home page, and you'll see where the Cancer Exercise Specialist directory is up there. Send us to this email here your name, your city, your state, and we have to have your zip or you will not come up in the system. So that's really important. If you want a phone number listed, and then any credentials you have, this is where you get to talk about you and all your amazing certifications and degrees. So make sure to send that over to us. That is part of your package. Now, basic information on taking the exam. You should have received a letter that said, dear so-and-so, thank you for purchasing the Cancer Exercise Specialist course. Your username is J Foley, for example, here, and your password is PASSWORD, #1! And that P has to be capitalized. You're going to put that in to the link that we give you, and then go ahead and log in. Next, you should see everything pop up. So you guys will see CES modules 1, 2, 3, and 4 in your dashboard. And you'll, of course, start by clicking on CES module 1. Now up here, you're going to see where you can watch the video. It is entirely up to you if you would like to watch the video first or if you want to read your handbook first. Really, whatever works best for you. You can even kind of go along with your handbook as you watch the video. But so important, when you're done with the video, you must check it right here as complete in order to go on to Module 1 test. And then when you're through with the 25 questions on Module 1, it will tell you if you passed. It will also give you an opportunity right then and there to see which ones you got wrong. And then you check that off. Now, if you did not pass, it'll give you an opportunity to go back and take that test again. There are very few problems with this process. However, every once in a while, somebody has a question about a question about one of the questions on the test. And more often than not, they did not read the question correctly or they overthought it. There are no trick questions here. Everything is answered in your book and in your videos that you're watching. So if you're still determined to find out an answer to something, then by all means email or call, and we'll try and look into that as quickly as possible. This is what the video should look like once you have it come up. And then this is what the test will look like. And you have the opportunity to go back and forth to the different questions on the test. And then at the end of Module 4, you will see right here, certificate. This is where you print out your certificate. Now, this is the pretty frameable certificate. Once you send us the information, your name, address, phone number, all that, we're going to send you another certificate, which will be for the purpose of getting your CEUs through various agencies. This is what your certificate will look like. And of course, the date that you finished the test will be put in right here. Okay, so now we are going to get into the meat and potatoes of Module 1. And what you need to focus on to successfully go through this course module by module, and not just to pass the exams, but to really gain an understanding of the material that is being presented to you. So that bears the question, what pertains to you as a fitness professional? Now, whether you're on the medical side of things, you're an OT, a PT, physiotherapist, or even a doctor, we can put medical/fitness professional, but obviously the implications will vary. So what pertains to you as a physical therapist might be different than what pertains to someone as, say, a personal trainer or a yoga instructor. So as I go through these situational slides, think to yourself about what applies in your situation. When you start off in your book and you come to prostate cancer, now I just randomly chose one of the cancers in the handbook to go through to give you an example of how the rest of them will work. So when we see the word radical, we know that this is an aggressive surgery. Obviously, all surgeries are, but radical is possibly a larger incision, more recovery time, more complex procedure. They're removing more tissue and possibly organs. So open surgery is kind of that subheading. That means it is literally an open surgery. It's not done laparoscopically through tiny little incisions. Then we drop down another notch, and you'll see that these are highlighted in blue because now we start to ask ourselves questions. Okay, we're not oncologists. We're not performing the surgery. So what does this mean to us as a therapist, as a trainer? If someone has a perineal prostatectomy, that means the incision is in the perineum. That's between the scrotum and the anus. So imagine having that person doing squats or any exercises that are going to put pressure on the pelvic floor. Probably not what we want to do for quite some time. The average healing time from these procedures to complete healing is about 12 weeks. And then we're only going to begin with body weight, just a few repetitions to see what that person can tolerate. Obviously, we'll want to factor in what their previous fitness level was, but if it's been several months and they've been out of commission, they're probably starting at a very, very low level, and they may still be going through cancer treatment. So right now, we are only focusing on the surgery. So if you will think of this as a mathematical equation, this is A. Then when we get into treatments, that's B. Lymphedema, that's C, and we're going to put it all together so that at the end, we can put together this exercise program or prescription. Okay, alternatively, they may have a retropubic prostatectomy. And in this case, the incision's in the lower abdomen with the incision extending from just below the navel all the way up to the pubic bone. So now we have a nice vertical incision. So think about this. As that patient is healing and there's scar tissue and maybe adhesions, they might be pulled forward either from the fear of standing erect, pain from standing erect, or the adhesions could be pulling them into forward flexion. So would that person would it benefit them to do crunches, to do more forward flexion, to exacerbate that forward position? Absolutely not. So as that fitness professional, or if you're the first person that sees them and you're the therapist, before we do anything, we need to get them standing straight up and down. We certainly don't want to do anything that is going to continue to encourage this forward flexion. So if it's in the perineal area, we're going to want to really take into consideration squats, anything with impact, anything with pressure on the pelvic floor. Start and progress very slowly with no weight or resistance to begin with, and then gradually, very incrementally adding weights when they are ready to. So I would work up to a good number of repetitions, 12 to 15 reps, before I'd even add weight. Focus on form, teach them how to do a Kegel exercise, how to contract their glutes, push through their heels when doing a squat. And with the retropubic prostatectomy, work on core exercises, get them on a foam roller, a physio ball, a Bosu balance trainer. Once again, depending on your client's level of fitness and their ability to balance. So if they have challenges with balance or they have neuropathy in their feet, then we have to do something that is going to be safe for them. You could put a Bosu balance trainer or an exercise ball in a corner so that you're in front of them and they have walls on either side so they're not going to fall. But beforehand, I would probably do things on the floor and just do any type of abdominal exercises that do not cause them to do forward flexion. So if you look in your handbook, you're going to see two variations on a crunch with the ball. One is supine and one is sitting upright with the ball, and they're pressing their arms down, and those are great alternatives. Lastly, we have minimally invasive surgery, which is the removal of the prostate and the surrounding tissue through small incisions. So the recovery time is much quicker, there's less blood loss, less pain, and they will probably be able to get back into their routine much more quickly than the person who's undergone open surgery. Now, the last thing I want to point out here, another really important factor for you, is that they have had pelvic lymph nodes removed. Now, if you know nothing more than the pelvis is in the lower portion of the body, know that they are then at risk for lower extremity lymphedema. We're going to talk about lymphedema in a little bit, but lymphedema is the swelling of the extremity following removal or radiation to lymph nodes. And what this does is it damages the lymphatic vessels and it interferes with the ability of the lymphatic fluid to flow throughout the body. So we know that the lymphatic system helps to defend our body against infection and other harmful agents. So anytime somebody's fighting off an infection, i.e. following surgery or radiation, there can be damage to the tissue that also affects lymphatic flow. Those things all are going to increase this person's risk for lymphedema, and in this case, lower extremity. So that means they can have swelling in the abdomen, the pelvis, either leg, either foot, and any of the toes. This risk does not go away with time. So the risk doesn't increase or decrease based on time since the procedure or since treatment, which means that if somebody's at risk, they'll always be at risk, and you need to take those precautions, which I will get into in later slides. So just to kind of recap here, this is how you're going to look at each of the different surgeries and the different types of cancer, and just, highlight what pertains to you. How is this going to affect their ability to perform any type of exercise or functional activity that you are doing with them in a therapy clinic or in a gym? Here you'll see a picture to give you an idea of what the incision looks like, both with the retropubic and the perineal here. So you can see how big this incision is, and then imagine these muscles tightening up through here, the scar tissue adhesion. And even though the muscles aren't directly affected, naturally when there is damage to the surrounding tissue and there's trauma to the area, the muscles will react by going into painful spasm, oftentimes from the ischemia or lack of blood flow to the area. So the direction and the location of the incision may affect their posture. It can also affect their range of motion. For example, if you're a yoga instructor and you wanted to have somebody doing any position that requires them to do a back bend, obviously this incision could interfere with that, whether it be fear, whether it be pain, or the scar tissue that limits the range of motion. So think about what the recommended exercises should be, and then what exercises to avoid. As I mentioned, avoid anything that's going to include forward flexion until they are able to stand perfectly erect. And in the meantime, the recommended exercises would be any that will help stretch this area out. So it could be just lying in a supine position, reaching their arms and their legs, their fingers and their toes in an opposite direction, or gently laying over something like the Bosu balance trainer that just has a slight just a slight curve to it. It's not like doing a full-on back bend. That would be too risky for them right now. So a couple examples here. Now, if somebody were in yoga, so right here, this is a great exercise for stretching, okay, to just get that little stretch. But if they were going to go all the way up onto their hands, they may not be able to do that yet if they have that limited range of motion. And this is what we want to avoid. We don't want to do anything that looks like a crunch until they have the ability to stand erect. And then, one of the contraindications is if somebody has severe forward head, having them do a crunch just puts more pressure on the neck and exacerbates that forward head. So there are things to consider in addition to the fact that they had any given surgery. Here is a photo or a picture of the lymphatic system. So sticking with the pelvic lymph node dissection, imagine that lymph nodes are removed right here in this lower midsection. With these pathways being restricted, potentially, the lymphatic fluid from the rest of the look for an escape route. And if it cannot find one, figuratively speaking, that's when there is a backup. So if you will envision the freeway at rush hour, and they may be 4 lanes of traffic, and every morning from 8 to 9 there are 5 million cars going down that road, down that freeway. What if we were to shut 3 lanes of traffic? We still have the same amount of cars every morning. So ultimately there's a backup, and that's the same way the lymphatic system works. So the first thing you need to know, is there a risk? And the factors would be, did they have lymph nodes removed? And did they have lymph nodes irradiated? Now, if they had both, their risk doubles. So keep that in mind. It doesn't change things because we're going to take the same precautions. It just means you have to take it a little more serious. And then the location. So where in the body did they have lymph nodes removed or irradiated? Because that will determine where we have to concern ourselves with and which lymph drainage exercises we do. The progression. When someone's at risk for lymphedema, it doesn't matter if they were an Iron Man or an Iron Woman previously. Whatever weights they were doing before, we're starting from scratch. Now, we only have to worry about the area that is at risk. So in this particular case, the lower extremity, which means that this particular person can do anything with the upper body. They can do any arm weights or resistance. They can do any poses that would require them to put their body weight on their arms. But we want to avoid adding resistance and to start off with very little in the way of repetitive motions with the lower body, because the more circulation that takes place, the more lymphatic fluid is pumped to that area, the greater the risk. And we'll start with lymphatic drainage exercises at the beginning or the end, or both ends of the workout. Let's say, for example, you have this person doing squats, body weight, and they're doing great. So they do 5 on one day, then they move up to 7, and then a couple weeks later, they're up to 12 repetitions, just body weight. So you say, okay, let's have you hold a 10-pound weight in each arm. And you have them do a few repetitions to see how their body does. They call you that night and say, my leg is swollen. We've taught them how to identify the swelling. And at that point, you have to do 2 things. One, you have to have them go to the doctor. They must get a medical clearance. The most important thing is to determine if they, in fact, have lymphedema, because if it's caught early, it's usually reversible. So make sure they go to the doctor for their benefit, and that they come back to you with a medical clearance, either stating that they have lymphedema or they don't, and if there are any precautions. And then you'll see where it says compression garment. If the doctor prescribes a compression garment, in this case, it would be stockings for the lower body, you must insist that they wear them when they are with you. Now, if you're in a hospital setting, things may be different, but as a trainer, I can tell you it is a liability. So it's no different than if the doctor prescribed this person insulin and you said, oh, don't worry about it, you forgot it, go ahead and just do your exercises anyway. So they must wear the compression garment if one has been prescribed. Now, if they don't tell you about it or they lie to you and tell you they don't have one, then there's nothing you can do. But have your liability release, everything in order, and the medical clearance is the most important piece of paper. So if this same person has their testicles removed, the side effect, which is really what the actual goal is. So with prostate cancer, oftentimes testosterone fuels the growth of the tumor. And so the first line of defense is to stop the production of testosterone. And one of the easiest ways to do so is to remove the testicles in a procedure called an orchiectomy. To have both of them removed is a bilateral orchiectomy. So without testosterone, you are going to have men that are going to be losing lean muscle, sometimes a significant amount. And as a result of a lowered metabolism and a number of different factors with treatment, they will probably gain weight, but it will be body fat, not muscle. They may also have gynecomastia or breast tenderness and growth and take on a more female appearance. As I mentioned, they'll have difficulty building muscle because there's no testosterone. So despite your best efforts, you're not going to get the results that you would, with somebody who has a good amount of testosterone. And infertility. So these things not only affect somebody physiologically, but they also can affect somebody psychologically. So here are a couple questions, guys, that people often ask me when they are going through Module 1. And one is, should I read all the material prior to watching the videos and or taking the exams? Well, that is entirely up to you and how you do best with test taking. I'm not one to read a book and memorize everything, so I learn best from watching the video. You will have an untimed open book test, and the reason for this is that in real life, you are going to have the opportunity to look back at your manuals. They are, your Bible of sorts, and in between your initial assessment and evaluation of your client, you can actually go look everything up and formulate the safest, most effective exercise programming. And I would rather have you do that than try and memorize everything, and maybe you get something wrong and somebody ends up getting hurt as a result. So really, whichever way you feel is the best learning experience for you is the best way to take the test. These are a listing of the CEUs that we offer, and most other certifying bodies will accept these CEUs, offering anywhere between 14 and 22 credits based on the coursework. If you need documentation, a lesson plan, or a letter to petition for CEUs through another organization, just let us know. And if you have a group of people who are going through the course or want to go through the course, and we do not have that group represented. So for example, I had somebody today who called me this evening and said, we all have NETA. Do you have CEUs for NETA? And my answer was no. But if a group of you sign up, we will go ahead and apply for CEUs. It's just not one that we come across too often. So we keep them to the ones that we see on a regular basis. Now, as you go through these slides, since we can't exactly do a back and forth Q&A now that this is recorded, feel free to send any questions to the cetiguru@gmail.com email address. Module 2 overview. We're going to talk now about breast surgery and reconstruction. Mastectomies have become fairly commonplace, unfortunately, in the United States and in fact globally. We are looking at, I believe the number is roughly 23 million cancer survivors globally by the year 2030, and hundreds of thousands are being diagnosed year-round everywhere. Now, I know we're on the mastectomy slide, which we're talking about breast cancer, but I'm talking about all cancer incidences. And the numbers for prostate cancer are just about as high as breast cancer, but it doesn't receive nearly as much attention as breast cancer. I got started working specifically with breast cancer when my mom was diagnosed for the second time, and she had undergone her second mastectomy. She had had an abdominal tram reconstruction, lymph node dissection, and this is back in 1995 when there was virtually no information available. So I had the good fortune of working with the chiefs of breast surgery at Georgetown, GW, and Johns Hopkins for 3 years to write the first book I published called Essential Exercises for Breast Cancer Survivors. So with mastectomies, the thing that we have to be concerned about across the board, there are a number of different types of mastectomies: modified, radical, simple, total. These rules, if you will, that I'm going to give you right now apply to all of them. And of course, the more tissue and skin that has been removed, the greater likelihood that there will be skin tightness or adhesions, specifically under the arm and across the chest. So, and I'll show you some pictures, but imagine incisions across here, and as this shortens and tightens up, how it will draw the shoulders forward. And if somebody already had round shoulder syndrome, forward head, protracted shoulders, you can imagine how this would exacerbate it even more. And I know I use that word quite a bit, but I can't think of a better one for the purposes of this conversation. And that would be made even worse if there was radiation to that area as well. So when we refer to incisions under the armpit, that is usually after a lymph node dissection, whether it is an axillary node dissection or a sentinel node biopsy. Either one, there will be an incision there, but with the sentinel node, they have a much lower risk of lymphedema. It's about half of what it would be with an axillary node dissection. Okay, so as you're thinking about working with this client and you're doing that postural assessment, you're going to see everything right before your eyes, that these are the things you're looking for. You're going to anticipate that rounded shoulder, forward head, and then you're going to kind of scan their back and look at their scapula. And do you notice that it's popping out into a winged scapula? If they've had an axillary node dissection, there is a decent likelihood that there is damage, temporary, but damage to the long thoracic nerve that's causing a ceasefire to the serratus muscle. And that being said, it's not firing properly. So for the person who presents with winged scapula, and for all intents and purposes, this is for anybody, regardless of if they've had an axillary node dissection, you're going to focus on exercises that will work on strengthening the serratus. So when you go to your book, there's going to be a section and it's going to say winged scapula, and it's going to give you 5 or 6 different exercises, or 1 or 2. It depends on which topic which round shoulders, forward head, winged scapula. Some have 5 or 6 pictures, others have 2. So, but you can also think of your yoga poses, or think of your Pilates exercises, or your therapeutic modalities. How can you do the similar movement with whatever modality you have, even in the swimming pool? They may have painful and difficult movement of the shoulder. So if your client can't get their arm up parallel to the floor, assuming that their uninvolved arm has pretty full range of motion, so this would be their norm, they need to see a physical therapist or an occupational therapist. That's kind of my rule of thumb. If in flexion or in abduction, they can't get their arm parallel to the floor, they need to see a therapist because they have other modalities. I mean, we can do assisted stretching and various range of motion exercises, but working with a therapist is going to be the best thing for that client to get the quickest results and the safest way possible. There may be numbness in that area. Sometimes it's temporary, and when the nerves reinnervate, there's a tingly sensation, which can startle somebody, but I oftentimes am asked, is this something I should be concerned about? My answer is always check with your doctor, but it's a very common side effect in this case. Usually the breast area remains, it's called insensate. There is no sensation. So that's not something that is likely to come back. And they are more at risk for recurrent infections. Now, I mentioned earlier how infections, the lymphatic system helps the body to fight infection. So if the lymphatic system is going into overdrive to fight an infection, then their risk of lymphedema increases at that time. And then axillary web syndrome, which I'll elaborate on in a moment. But I just want you to get a basic understanding of these things before I move on to the next slide. So here is our, just basic anatomy drawing. And you can see the direction of the fibers of the muscle. So when you think of this incision going through the pectoral area right here, and we have this horizontal incision, imagine as this all shortens and draws inward, what that's going to do to the posture. Axillary web syndrome is a painful and functionally limiting complication of breast cancer treatment. It is most likely due to lymphatic thrombosis after lymph node resection, so after they've removed lymph nodes. And patients describe cord-like structures in the axilla that extend into the distal arm, and they cause pain, limited shoulder range of motion, and functional compromise. So the reason I didn't highlight pain is, that would be more along the line of the therapist to be addressing, but as a trainer or fitness professional, we certainly want to focus on improving shoulder range of motion and working on functional activities. So I don't care if somebody can do bicep curls with 35 pounds if they can't even reach into the cupboard to get a coffee cup. Lymphatic cording is a visible web of axillary skin that overlies palpable cords of tissue. And I'm sure you're familiar with what somebody who has very vascular arms looks like. It's similar in appearance, although completely different process. There is a 6% incidence between 1 and 6 weeks. It can occur in the axilla, the elbow joint, the wrist, and/or in the trunk. Now, the physical therapist needs to perform long tissue stretching and myofascial techniques. That should be left to the therapist. But then the patient has to do a home-based stretching program, and this is where the fitness professionals come in. And this is where we're going to bridge this gap so that the patient can safely go from therapy right to the post-rehab and work with a cancer exercise specialist. Active range of motion and passive range of motion should improve. Pain will most often decrease, but there may be visible signs of cording that are always present. So if someone has undergone a lymph node dissection, we have to ask ourselves, where were the lymph nodes removed? So in the case of, let's say we had a right axillary node dissection, you are going to this client is going to be at risk for swelling in this pectoral area, possibly in the lat area on the same side, and then anywhere down into the arm and the fingers. We're going to start with upper extremity lymph drainage exercises, and then that person should also finish their workout with upper extremity lymph drainage exercises. These are all in your book in the lymphedema section. And there are also some videos on our YouTube channel that you can watch as well, and the link is on the website at thecancerspecialist.com. You need to go through that slow, gradual progression. So this person would have no limitations on their lower body. They can do walking lunges and squats from, here to Timbuktu. But with their upper body, we are going to start with no weight. Then we're going to go to 1 pound, 2 pound, 3 pound, 4 pounds, so on and so forth. And even though that seems overly simplistic and boring, and you're going to have clients that are going to want to move along faster, let's say you're doing great and they're lifting 4 pounds, they're doing shoulder raises, and you go, okay, let's bump this up to 8, and then their arm swells up. You don't know that they wouldn't have been fine at 5, at 6, at 7 pounds because you jumped right to 8. And now we've got to go all the way back to 4 pounds or before they had any swelling. Not to mention that they now need to go to their doctor, make sure that they don't have lymphedema, or if they do, it needs to be diagnosed. And now they probably will need to wear a compression sleeve while they are exercising. So assuming that they have gone back to their doctor, make sure they come back with a new medical clearance. It doesn't matter if you have a medical clearance from when you first started to work with them. Anytime they need to go back to the doctor for any event, they need to come back with a new medical clearance form. Breast reconstruction is very complicated because in many instances we're going back, or the patient is going back a year later. So they've had their mastectomy, they have undergone chemotherapy, they wait until their immune system has recovered, and then they go for their reconstruction. And there are a number of different reconstruction procedures available based on the patient's needs, functionally, based on any injuries or muscle issues that they already have. For example, if they had a rotator cuff injury, then they would not be a good candidate for a lat flap, which will use the latissimus muscle to reconstruct the breast. So what you're looking at here is an abdominal tram, where they're actually going to split the rectus abdominis. They will cut out this football-shaped section of tissue, fat, skin, and keeping the rectus attached, they will then tunnel this up through the torso and bring it out through the mastectomy scar to create a breast mound. Now, this will definitely affect posture. So for the first couple weeks or first month, this person is highly unlikely to be sitting up or standing up straight. They will probably have drains all over the place, huge incision from hip to hip. This is actually a cosmetic tummy tuck. And they're afraid, they're in pain, and then as the scar tissue and adhesions perhaps form, that can draw them even more into forward flexion. But then what happens after a month or two, this is going to give way to weakness, particularly if they did a bilateral abdominal tram, leaving this patient with no rectus abdominis. Now we've got this area that's probably going to be overstretched. The lower back, the erector muscles, the QLs, even everything down to the multifida, all the spinal stabilizers, are going to be working overtime, compensating somewhat through it's synergistic dominance in a sense, that they are doing what this can no longer do. So now you're very likely to see excessive sway back or lordosis. So the natural thing would be to strengthen the rectus abdominis, but now if we have them do crunches, first of all, if they've had a bilateral, they won't be able to. But if they had a unilateral, then one breast is going to contract while the other side of the rectus contracts, because this area does not know, the brain does not know that the rectus abdominis is up here now. So it makes absolutely no sense to do crunches or anything with forward flexion. Whereas with the prostatectomy, eventually that person can, once they stand up straight. But with this particular incidence, they should not ever be doing crunches and probably will not be able to. But they certainly need to do a great amount of core exercises, everything and anything, as long as it is safe and appropriate for that particular person. So their range of motion, as you can see, is highly likely to be compromised with all of these incisions. Usually the only area in this particular scenario that won't be is internal rotation, because if they're internally rotating their shoulder, they're going into the direction of the scar tissue, versus externally, they're pulling against all of that scar tissue, which makes it difficult to move the arm. So we don't want to do any exercises in those planes of motion that involve resistance until they have 90% or better of the norms for range of motion. And that's all in the goniometric measurements section of your book. If your client has expanders, so they're opting for implants, what they will do initially is put in expanders under the skin to stretch out the skin so that there is room to accommodate a breast implant. While they have the expanders, they cannot do any chest exercise, none. So nothing that involves chest contraction. And even a stretch, I would not do that while they have the expanders in. But once the expanders are out, then you can begin stretching with very limited range of motion. The expanders can, the breast implants can pop out of the pocket. It is not common, but it does happen. So it's not anybody's fault, but you want to be smart about it. So start and progress slowly with range of motion. Then once you have the range of motion, then you go to 1 pound and 2 pounds and 3 pounds and so on and so forth. So the recommended exercises and the exercises to avoid are going to vary depending on where they're at in the whole recovery process. And these are the same slides that I showed you with prostate cancer, because we have the same issue with not wanting to do crunch type activities, but knowing that this modified cobra position is a great way for somebody to gently stretch out that area, and they can control how much they're stretching versus having them lay in a supine position over a ball. Not only is that dangerous because they may fall off, but they may do more of a stretch than they were actually planning on. So you can do anything that will stretch out the abdominal area until they're standing erect. That's our goal. And then all types of core exercises. To counter the excessive lordosis, and these are some pictures from your books, we're going to stretch out the lower back, which is heavily taxed as this all shortens, puts a lot of stress on the muscles back here. It could also be attributed to tight hip flexors, so we can do things to stretch the tight hip flexors, and you can think of any other exercises that would stretch the low back or stretch the hip flexors. And we are going to do exercises. These are 2 examples of exercises to strengthen the glutes, which are the opposing muscle groups to the hip flexors. So as we strengthen or contract the glutes, we, through reciprocal inhibition, we automatically are going to be stretching out the hip flexor muscles. And this is a way that somebody, I mentioned this earlier, that somebody can do a crunch. So not necessarily somebody who's had an abdominal tram, but anybody who has lordosis, we want them to do abdominal work. They have forward head. We can't have them do a regular crunch on the floor. This is an awesome option where with very rigid arms, they press down into the ball and they'll feel the same contraction that they would if they were doing a crunch. And this picture will show you some of the different reconstructive procedures. So the breast implant is placed beneath the pectoral muscle. And so anytime they contract their pec, the implant is going to move. The deep inferior epigastric perforator it allows them to use the abdominal fat without compromising the rectus abdominis muscle. So that is an awesome option for some people, but it's not always covered by insurance. It just depends. So anyway, I'm not going to go into too many details here, but you can look all of these up in the books. They're all of the surgeries are covered in there, and we'll talk about the modifications for each of them. Next, I want to move on to cancer treatment. So now we've just gone through the surgeries and how they affect posture and range of motion. Now we're going to add treatment into the equation. So now we've got our A and going into our B part of the equation. So let's go back to what pertains to you as either a health or a fitness professional as we look through these slides. Chemotherapy. We are all too familiar with the nausea, the vomiting, the weakness, the hair loss. But as we go through these side effects, which ones are going to be a concern to us in our niche, our whether it's being a personal trainer or a physiotherapist? So nausea, obviously somebody who has nausea is probably not going to feel like exercising, but if they have vomiting or diarrhea, they cannot exercise for 24 to 36 hours. And this is a time where they need to get their energy back. They need to rehydrate and re-up their electrolytes. So there will be an instance with a gastric bypass surgery, which you'll read about in your book, where they may have chronic vomiting and diarrhea. And in a situation like that, then I would say go ahead and let them exercise. Otherwise, they'll never be able to exercise. But we just have to make sure that they really stay hydrated and work out at a low intensity. With fatigue, obviously, that tells us what their level of intensity is going to be. And when they're going through treatment, they should only be working out at about 20 to 40% of their Carbonin heart rate, which will take into consideration their resting heart rate, which is often lowered. And then with anemia, that can exacerbate the fatigue. So they're operating at a very low level. Immunocompromisation, their blood cell count is usually low. This means that their immune system is compromised. And when they go into a public place, particularly something like a gym, the risk of infection is much higher. So, one, do not train someone whose immune system is compromised if you have even the slightest inkling that you are getting sick. If they are working out in a public place, everything should be sanitized. They should not drink from a public water fountain, so they bring their own water bottle. Use a clean towel over a public mat or have them bring their own mat, and recommend frequent hand washing, or even recommend that they wear exercise gloves. I'm not going to go through everything on this list. You have it in your book, so I'm just going to talk about what you really need to focus on. Peripheral neuropathy, it's a side effect of diabetes. It is also a side effect of chemotherapy. And this is tingling, numbness, burning sensation, and it can be very painful. It can happen in their feet or their hands. So if they have peripheral neuropathy in their hands, you're going to want to avoid anything that requires fine motor skills. So if they were holding a band and didn't have that sensation in their hands, they could let go of the band and hurt themselves or you. Same thing with a dumbbell. If it is in their feet, if they have peripheral neuropathy in their feet, they should not do any high impact activities. So as we're going through this list, as you're going through, working with a client, these are the things that are going through your mind as you're putting together either the workout for that person. Chemo brain is short-term memory loss. How can that affect their exercise program? They may have difficult time retaining the information from one exercise session to another. So make sure to go back over it, talk about the form, explain why they're doing it. While they're taking a break, this is an educational opportunity for you. If there is a port, and it will be pretty obvious, particularly if they have it in their chest. It looks like a box under their skin. And this is so that they can have chemotherapy given through that port, or they can have IVs, they can have blood drawn, and that way they don't have to keep tapping a vein. So it is subcutaneous, and you're going to want to be careful of any pressure on that area. So if they're lying prone or you're putting them up against a piece of equipment, put some thought into that, because it could be very uncomfortable for them. Also, be careful of range of motion in the area where there is a port. Because chemotherapy can damage the heart and lungs, we know that as part of their exercise program, they must be doing cardiovascular exercise. Obviously, while they're undergoing treatment, it's going to be at a very low level and maybe for a very short period of time, but they will progress. And as they move into survivorship and post-treatment, then they can and should be doing more cardiovascular exercise. Diabetes is a long-term side effect of chemotherapy, and so we want to make sure that they are working with a registered dietitian specializing in working with cancer. As a personal trainer or a physical therapist, even the best of us cannot make these recommendations unless you are a registered registered dietitian. It is out of scope of practice. And then lastly, osteoporosis is also a long-term side effect from chemo. If they also don't have, let's say a woman doesn't have estrogen being produced anymore, then that's going to increase her risk of osteoporosis, so that we have to do weight-bearing exercise with that person. If they don't like lifting weights, then think of another way that they can get weight-bearing exercise. But we have to provide cardiovascular, we have to do the flexibility, range of motion, and we have to do weight-bearing exercise. And at different stages, one might be more important. So you may put more emphasis on one than the other, and then it changes as they go through their recovery process. Because of mouth sores, they may have difficulty eating and drinking, which can end up with malnourishment. So their level of intensity will be very low. Definitely consult with the doctor on that and find out if they even want them exercising. And then they will probably have lost a lot of lean muscle. So building lean muscle is going to be very important. And then this just reinforces what I just mentioned with appetite changes as well as mouth sores. With radiation, they may present with a mild to moderate pink color or redness. Now, the darker somebody's complexion, the less likely you would be to even see a burn, but if they have fair skin, there may be a more dramatic reaction. The skin can be dry and sore and even more sensitive to the touch. So take that into consideration when you are placing somebody on a piece of equipment or having them lie prone or supine. Ask them, talk to them regularly about how they feel, if this hurts, if they're uncomfortable. And some people won't volunteer that information. So look at their facial expressions. If they peel or blister, we end up with an open sore. So depending on that location, that open sore can lead to an infection, which can increase their risk for lymphedema. Now, we know that because they've had radiation, that is a risk factor for lymphedema. If they've had lymph nodes removed as well, then it doubles the risk. And then this just makes it a greater risk while that blister is an open sore and the lymphatic system is working to fight any potential infection. They may have tanned or even slightly pinkish skin for up to 6 months, and darker skin will appear more tan and less red, but it can still be very uncomfortable. Okay, so now we're going to discuss lymphedema in a little more detail. Again, what pertains to you and your modality. Here we've got another example of the lymphatic system. Side effects of lymphedema include swelling, which is the obvious one. That can result in decreased arm or leg function, depending on what part of the body is affected, and Also, it can have numbness in the hands, fingers, legs, feet, and toes. So think about that when you're deciding what exercises somebody should be doing. It can happen anytime after surgery. I already mentioned this. The risk does not increase or decrease with time. So whether it's 1 day or 99 years later, they are at risk for lymphedema in the area where lymph nodes were removed or irradiated. Now, the only thing that can change that risk for the purposes of what we're speaking about is as a client ages, the risk goes up. If they have poor nutrition, the risk goes up. And if they have a higher percentage of body fat, the risk goes up. So aside from diabetes and heart disease, we also want to help a client to reduce their percentage of body fat because that will reduce their risk of lymphedema. And rarely they can have a cancer of the lymphatic system called lymphangiosarcoma. So what are precautions? These are listed in your book, so I'm not going to go through them one by one, but please take these, copy this handout, and give it to anybody you work with, who obviously who has cancer and is at risk for lymphedema, because this can be the difference between somebody getting lymphedema or not getting lymphedema. And I use this in a lot of my promo material. This is something of value. So when you're thinking of ways to spend your marketing dollars, remember that people who take your pens, eventually they're going to lose them or they're going to run out of ink, or the magnet that you give them might be ugly. But if you give them something of value, something that they have a need for, the likelihood of them keeping it is astronomically higher. So with lymph drainage exercises, which are all in your book, they're listed and they need to be done in the order that they're presented. They both start with crunch type exercises. So if they can't do a crunch, then, maybe we focus on deep belly breathing, if somebody had an abdominal tram. But otherwise, they have the alternative of doing the quasi crunches with the balls or regular crunches, and then pelvic tilts. And what this does is it helps to get any lymphatic fluid that is pooling in the torso to start circulating, so that when we then are either doing upper or lower extremity lymph drainage exercises, that lymphatic fluid can leave the limbs and have a place to go to. Now, if somebody has had lymph nodes removed or irradiated throughout their body, say in the case of somebody with lymphoma, then they're going to have to do both upper and lower extremity lymphatic drainage exercises. All right, so we are finishing up with Module 2, just in time here with about a minute to go. So I had some people write in questions earlier, not earlier today, but from earlier workshops and webinars. So they said, what if somebody's 10 years out? Do I still need to worry about lymphedema? And this will be the third time I said this. The answer is yes. You always have to worry about lymphedema. Now, you don't want your client to be neurotic about it, but you just give them the precautions. What they do on their own time is entirely up to them. But when you are working with them, if they have been prescribed a compression garment, so I'm going to go down here, actually, a segue into number 5. If you know they have a compression garment and your client forgot to bring it, what do? Well, you should not work out with them. That is a liability to you. If something happens, and it can come back on you for not adhering to doctor's orders, it's going to put you in a precarious position. So let your client know from the beginning that they must have their compression garment with them for every exercise training session. If they have not been prescribed one, it is not an issue. I also had just covered this in my last slide. What if my client has lymphoma and has had lymph nodes removed or irradiated throughout their body? Then we will begin and end with both upper and lower extremity lymph drainage exercises. And it's really easy to work them both into the cool down from a group exercise class or the end, last 10 minutes of your personal training session. And it can be a combination of stretching and lymph drainage exercises. My client is currently in treatment but has a lot of energy. Can I push them beyond what is recommended? Not really. Again, it comes down to protecting your client and yourself. And if you end up in court and your client's in treatment, they should only be working out at 20 to 40% of their carbonin heart rate, and you had them working at 70, and there's some way that they can, prove that, then you are being negligent. So you have to really stay within the parameters of what's put out there by the American Cancer Society, and follow those that have done the research, which we have cited throughout the material. Lastly, during our training session, my client's arm appears swollen. What do I do? Well, you stop exercising and say, Jane, John, whomever, I want to make sure this isn't lymphedema. Hopefully it's not. And if it is, because we're catching it early, it's very likely that it is reversible, but you need to go see your doctor, have them evaluate it. And then before I can see you again, I need you to come back with a medical clearance form. All right, moving on to the second part of our webinar here. We're going into the Module 3 overview. Exercise testing and assessment. Now, this is the modified Thomas test. Yesterday, I had a new client, 75 years old, stage 4 pancreatic cancer, lost about 35 pounds, primarily lean muscle, very frail. This test would show me if he had tight hip flexors, tight quads, tight IT bands. It explains it all in your book. But I would run more of a risk having him lie back onto this table, if he was even physically able to do it, than the rewards were worth. So, when you have somebody that is that frail, even though I give you a whole bunch of different testing protocol in the book, it doesn't mean you do it for everybody. It was all I could do to have him stand up for the 5 or 10 minutes that it took me to do a postural assessment. And you have to say to yourself that if somebody is that deconditioned, they're starting at the very beginning anyway. I mean, basic range of motion, functional activity, helping them with activities of daily living. The last thing I'm worried about is, how much they can bench press or how many squats they can do on a rack. If you do have somebody do the overhead squat test, which I think is a fantastic test, because we can see whether their knees are knock-kneed or bow-legged. We can see if their arms fall forward or go out to the side. It usually indicates tight pecs, tight lats. And all this is also in your book. There are actually charts that tell you, if somebody's performing an overhead squat test and their arms fall forward, these are the tight muscles and these are the weak muscles. So it stands to reason that we are going to stretch the tight muscles and strengthen the weaker muscles. So if somebody is bowing out to the side here, then we need to strengthen the adductors and we need to stretch the tight abductors. But did I have my guy do this yesterday? Absolutely not. And just standing, I could see a lot of this with his knees and his feet excessively supinating, knees laterally rotated. So you can see a lot in the postural assessment. And that is a test that should be done with every single client, regardless of age, or whether or not they are orthopedically challenged or have a disease, because you learn so much from that postural assessment. Honestly, I don't know how you can call it a personal training or individualized program without doing that. So we have to determine whether we're stretching or whether we're strengthening or both. And a lot of this is trial and error. Although, we're trying to keep the science in exercise, a lot of it is going to be affected by other factors: the person's age, their previous fitness level, whether or not they're undergoing treatment, how far out of surgery and treatment they are, their motivation, their self-confidence. There are so many factors. But what I'd like you to think about as you look at these pictures are which muscles are tight, what muscles are tight, drawing this guy's shoulders forward into that protracted state and with that forward head, and then which muscles are overstretched. So would you say to yourself, this person needs to strengthen the upper back and stretch the chest? Or would you recommend that they do bench presses because maybe their chest muscles are weak and that's why his shoulders are collapsing? If you choose the wrong combination of exercises, so what I just stated to you was absolutely wrong. We don't want somebody who has protracted shoulders, round shoulder syndrome, or upper cross syndrome to do bench presses or any type of pressing motion until they can stand straight up and down. Once they are balanced, then they can do chest and back. But bear in mind that everything we do throughout the day is in the front of our body. So we're naturally going to have to do more posterior work to keep it balanced. You're going to learn how to use a goniometer if you have not used one already. The explanation is in the book. It's in your videos, and this is the axis of rotation. The stationary arm will actually be the one that is attached to the circle, and the movement arm is the one that moves like hands on a clock. And this is what you're going to see in your book. So these are the norms, and what we're looking for is 90% or better of this lower number. So if your client has at least 135 degrees in shoulder flexion, then if you want to put a weight in their hand and have them do a pullover, that's fine. But until that point, you want to just continue to work on range of motion, and realize that a lot of people will gain their range of motion back and then they stop stretching and they go back to a limited range of motion. So make sure that they continue stretching as part of their routine. And you'll see where the stationary arm is. So it tells you it's in line with the body. The axis is here at the shoulder joint. And then the movement arm is in line with the elbow and the shaft of the humerus, and essentially is moving with the arm. You're going to want to look at what we tell you with each of these planes of motion to watch for the scapular movement, that there's not excessive movement through here. And this bottom part is primarily for physical therapists, physiotherapists, who are going to understand this in a little more detail. But if you start to see your client compensating, they're lifting off the table, or they're cringing, then have them back off and take your measurement right there. As you figure out which plane of motion they are limited in, we have a baseline, which is great because we can look back later to see what the improvement is, or, perhaps there wasn't a significant improvement and we have to reassess what it is we're doing. It helps with the accuracy of measurements. Oftentimes, therapists will just eyeball it, and that's fine. But as a fitness professional, I want to have the most accurate measurement possible, so that when I share that with a physical therapist or the doctor, that we're speaking the same language. Don't progress to resistance training until they have 90% or better range of motion in that particular plane. So if somebody can't do weights in flexion because they have limited range of motion, but they are fine in extension, then they can go ahead and do tricep kickbacks or dips. They're just not going to do a pullover. Think about the contraindications. There are absolute contraindications, and then there are recommended exercises or modifications. So absolute is, nowhere, no how. They absolutely cannot do it. And actually, let me back up there. It's in your book, and you'll see there's a chart. So one absolute contraindication would be while somebody has a fever. Absolutely no exercising. Whereas the vomiting and diarrhea is a recommended take 24 to 36 hours. It's not 100%. You cannot do this under any circumstances. So you'll see both charts in your book and understand that those need to be applied under those various circumstances. You will have a section on stretching, and you must know that the safest form of assisted stretching is active isolated stretching. I talk about passive stretching, manual stretching, and active isolated stretching, and while those are all great, the safest form is going to be active isolated. I'm sorry, I said active isolated twice. I meant PNF stretching, proprioceptive neuromuscular facilitation. So if you allow the client to initiate the stretch and then you go into a deeper stretch, barely moving, so incrementally, maybe a centimeter, and you repeat that multiple times, the client gains the benefit of the assisted stretch, but you're not taking it upon yourself to determine what the range of motion is. And then, of course, you can teach your client how to do passive stretches because we want them doing them on a regular basis. So choose the stretches that are appropriate, going back to these muscles are shortened and these muscles are overstretched or weakened. The muscles that we determine are shortened or in some cases spastic, they need to stretch. So this will help improve range of motion, and it's also going to help with lymphatic drainage, which is awesome. So these neck stretches, one of which you're seeing here, are actually part of the upper extremity lymph drainage exercise protocol, the warm up and the cool down. So a couple questions we have here for module 3. And I already answered the first one for you, really. My client is very frail. Do they have to do all of the assessment tests? And the answer is no, not if it puts them in harm's way. So you can either modify the assessments if there's a way to do so. For example, if your client can't lie in a supine position, you can take the goniometric measurements, having them sit in a chair. Just make sure that you notate that in your chart, so if you are sending that to a physical therapist or doctor, that everybody's measurements are lining up the same, because otherwise, somebody thinks somebody else doesn't know what they are doing. You are going to have clients who are excited. I mean, even though their body isn't wanting to do what they wanted to, they're excited to get started. They want to feel better. They want to feel healthier, and they may be a little overzealous. So sometimes you have to be the one to say, we don't really need to do this. Do I really need to do a push-up strength for muscular endurance? And particularly if somebody has round shoulder syndrome, or if they have had a mastectomy or have expanders in, absolutely, we do not want to do a push-up test. So think about the different testing protocol. Even though they're all in the book, it doesn't mean they are all to be used for every single client. If your client has had neck surgery, should you manually stretch them? I am going to say to steer clear of that. Show them how to do the neck stretches on their own. Teach them, how to sense when they need to stop, because people don't necessarily understand the difference between discomfort in a stretch and actual pain. And we certainly don't want anyone to feel pain. There should only be a mild stretching sensation with any stretch, whether they do them on their own or whether you're doing stretches with a client. So constant communication is really important in this part of the exercise session. And I will tell you, however, that as a new trainer back in the early 90s, I had the good fortune of working with a more experienced trainer who taught me how to do assisted stretching. And it has been, without a doubt, one of the best modalities that I've had to use for client retention, because people love the way it makes them feel. They love finishing an exercise session by being stretched. Different states, maybe countries, have different mandates, so make sure you know whether or not you are allowed to touch your client where you live. And lastly, my client complains of pain when trying to take range of motion measurements. What do I do? First off, I just was talking about with stretching, same thing. If they say that it hurts, back off. Or, by all means, let them know ahead of time to have them stop you before they get to the point where it's pain. But sometimes it comes on really quickly. So if they say, ow, that hurts, back off a little. If they still say it's uncomfortable, then just scratch it. Don't do that particular plane of motion. But they're going to have some range of motion that is pain-free, and that is what we want to be able to test. Now, physical therapists, occupational therapists, they're going to be looking for passive and active range of motion, where I've simplified it a bit more in the book for those of you who are first learning how to do goniometric measurements. As long as you do it the same way, in the same position every time, we're really not looking to compare somebody to the rest of the world, but simply how they are on day one compared to where they're at 2 months from now and 3 months from now, so that we can see that the exercises that we are having them do are making a difference. Because if they're not, then we have to come up with something else that's going to work better. All right, we are now moving on to module 4. So wrapping things up here. 76% of cancer patients will be affected by fatigue, and this is severe fatigue. This isn't the fatigue you and I know, even on your worst day. I have had people tell me things like they worked all through treatment and they would literally fall asleep going up the stairs as they got home in the evening, so they would set an alarm clock on the stairs. And the only thing I can think of is when you are so tired, you've been studying for exams, or you're an athlete, you've been training like crazy, whatever, and you lay down, you fall asleep on the couch watching TV, and under no circumstances are you getting off that couch. If your teeth rot out of your head, you're not getting up to brush your teeth. So imagine being like that every day for months on end. And this is made worse when somebody undergoes chemotherapy and then they follow it up with radiation, or vice versa. So when they have adjuvant treatments, you have all these toxins in the body, and the body is using all of its energy to heal. So we have mental and physical fatigue. The mental fatigue happens when basically they've exceeded their capacity. So people are thinking about treatment decisions and reconstructive procedures, and who's going to watch their kids, and will my partner or spouse still love me? Will I have a job? And they literally cannot process any more information. And so this is a time where their attention span is really low. They have a difficult time learning new information. So you have to think about what are their limitations going to be. This isn't where we're going to have them do walking lunges with dumbbell curls and then going backwards with hop, skips, and jumps. It's too much for them to even process. So keep exercise simple and free of distractions. If you have a private room or can even do a home workout, this is a great time to do so. Not only that, but the risk of bacteria and germs will be less as well. And know how to make modifications. So for example, let's say, squats are a really important functional exercise. But somebody is so tired and so weak, they're afraid if they're doing a squat, they're going to just fall on their butt. So what if we have them holding onto a chair rail or a treadmill, and we put a chair behind them so that they know that if they fall, they're only going to fall to a seated position. We want them to feel confident in their ability to do whatever it is we have them doing. And fear can be completely debilitating. People think their muscles have failed them, but what it really is the fear keeping them from being able to move. It almost paralyzes them. So there's a lot of psychology involved here. And if we give them difficult exercises, they are going to be frustrated and they're going to quit, and that is going to defeat the entire purpose. So we want to keep things as fun and lively as possible. Like I said, free of distractions, and that could even include music or the sound of, barbells and stuff clanking in the background. But if they like a music or a particular environment that maybe they want to work out in the park, that's awesome. Whatever's going to keep this person engaged and relatively excited to be there. And then chemo brain is also known as attentional fatigue and mental fatigue. That is a question on your test, hint, hint. And it is basically short-term memory loss. We used to think that it dissipated after about 2 or 3 years post-treatment, but we are finding that this is ongoing for the majority of people who have undergone chemotherapy. And add to that fact that many are middle-aged and older, and our memory tends to surprise us sometimes. I'm speaking from experience. Survivorship. Everybody is or thinks they can't wait to be done with this treatment, and oh my God, the last radiation treatment, the last chemotherapy. And of course, they're so happy to be on the other end of that. But then there is this safety net that has been there for them for all of these months. Their medical team, these fellow cancer survivors who maybe they were talking to while they were getting their chemotherapy, and they're left feeling very alone. And now maybe they're not the center of attention. Everybody's not looking after them, asking them how they can help, and that's a very scary feeling. You don't know how to live your life the way you used to live it. You're in fear of getting cancer again. You're in fear of eating the wrong thing, of drinking the wrong thing, of doing the wrong exercise. And that sometimes that can really spiral into depression. So exercise, we know all the benefits during treatment, but in recovery, it's going to lead to patients that are feeling they have better self-esteem, they have more self-confidence. It's going to give them that much needed energy and a sense of fitting in. So, as their hair grows back, as their body starts to take the shape that it used to be, some people will have lost weight, many will have gained weight, and we can help them to get back to where they feel good. And as a fitness or a medical professional, we also have to know what the limitations are, because sometimes people are not going to lose weight easily. If they're on hormonal therapy, they may gain 25 pounds, and it is really hard to get off. So we come up with realistic expectations. We want people to succeed. So if we set the expectations, if we set the bar too high and set them up for failure, we're crushing what self-esteem they have left, or that they have found again. Working with other cancer survivors is great for many people because of the camaraderie that it affords them. And some people like talking about their experiences and what they're going through, what they've been through. But you'll find other people who don't want to see the word cancer. Do we use the word cancer? Is this a cancer class? Is this a survivorship class? I have had people who proudly wear their, Race for the Cure or Live Strong shirts, and I'm a survivor. And I have had other people that don't want anyone to know they've had cancer. They don't want to draw attention to themselves. So this is really a case-by-case scenario. I have also found that even in the most beautiful hospital-based exercise programs, many of them fail because cancer patients do not want to go back to the place that they had radiation, that they had chemo, that they were told you have cancer. So having a health club, a medically based fitness facility, yoga or Pilates studio or therapy clinic that is away from the hospital can be very advantageous and helps the person get back to normal. What is that new normal for this person? And, everybody's going to react in a different way. But as we bridge the gap from cancer treatment to survivorship, we give people the ability to take control of their lives and their bodies at a time when they feel that they have had no control. And that is the most empowering thing we can do for anybody. There's a section on nutrition, and it is simply there as a reference for you. It was written by Dr. Glenn Giro, and his contact information is in the book. We will also be doing some webinars with him, so look for information about that. But as I mentioned earlier, unless you are a registered dietitian and you specialize in working with cancer patients, please do not make any recommendations. What you will see in the book is pretty general information for the public, but you don't want to recommend doses or specific types of food because there can actually be reactions to some of the treatments. So telling people things like, hey, these are cancer-fighting foods, talk to your doctor about them. That's what I would like to see. Or if you want to talk about the basic food pyramid, and basic dietary recommendations, that's fine. But one example is soy. Soy can be great. Tofu, soy milk, and many people think of it as cancer preventive. But if somebody is estrogen receptor positive, which means that their cancer grows in the presence of estrogen, soy is a phytoestrogen. The body looks at it the same as if it were estrogen produced by that person. And so there's a risk of that soy product helping to initiate cancer cell growth. The goal here is for us to bridge the gap. The first person that the patient sees is, of course, their doctor, their surgeon, their oncologist, their medical team. Then, if they're lucky, they get referred to a physical or occupational therapist, but that's not always the case. And then hopefully, then the next step is to have them referred to a cancer exercise specialist. But as a cancer exercise specialist, particularly if you're on the fitness end of things, we need to create these relationships with the medical professionals so that they are going to feel confident in referring to us. So we have to build that, that like and trust factor before they are going to send their patients. And then ultimately, we all form this team that obliterates cancer in the sense of, we take them into survivorship and let their cancer treatment be a thing of the past. And we all know that exercise helps to prevent cancer. We all know that exercise helps during cancer treatment and now into recovery. But still, the majority of people are not either told to exercise by their medical team, or they are told and there's no follow through, or they are told there's follow through, but they quit. So all of these things have to be part of the equation. And that's where you, as a cancer exercise specialist, truly dissecting their health history and their initial assessment and individualizing this person's program is the way to success. Because yes, we can do a group exercise class and it can be effective. And I'll talk about that more in future webinars as well. But the bottom line is when you take away the individualization, you're not going to get the same level of results. And no two cancer patients are going to have the same reaction, even to the identical treatment. So what you're going to find in your 4 books is some intense information, very comprehensive, which should reinstate the fact that you can't do a cookie cutter workout here. And I'm also happy to field any questions as a result or in the aftermath of this PowerPoint presentation, or when you're going through your material. Please write us at cetiguru@gmail.com. Then you are going to finish your Module 4 with a couple of case studies. One of them will be done for you so you can see how it's done. And then the other ones only give you bullet points. So I'm not giving you any information here. I'm not telling you what the assessment was, how they did on any of their tests or what their health history is. So this is something that I want you to think outside the box. and say to yourself, all right, we have a 65-year-old female who, oh, by the way, is sedentary. And if we go down to the bottom here, we know she's already 30 pounds overweight. So the fact that she's sedentary, I think we have a pretty good sense of where we're starting with very basic functional activities. Also, we know that she is going to be at risk for diabetes because she has so much extra body fat. So we've got to work on helping her to lose this weight, recommending her to a registered dietitian, getting her to do sufficient cardiovascular exercise, obviously as she can tolerate it, because how much can she possibly do? And what type of cardiovascular exercise is going to be okay for this person? Now, I'm not even taking into consideration that she may have orthopedic conditions, which obviously would add to the equation here. So we know that she's had a right modified radical mastectomy with a node dissection, and this was done 3 years ago. So as far as her blood counts and her fatigue, she should be pretty much back to normal now, 2.5 years, 2.5 years later. But because of the right modified radical and the node dissection, she is probably going to have exacerbated round shoulder syndrome, forward head, general poor posture made worse by the mastectomy, scar tissue adhesion. And then because she's had an axillary lymph node dissection on the right side, she will be at risk for lymphedema on that side. So we are going to take the precautions and have her do the lymph drainage exercises for the upper body. We are going to give her all of those notes about how to prevent lymphedema. And of course, if she's been fitted with a sleeve, then she must wear one during the exercise session. She may also present with winged scapula on that right side if there was damage to the long thoracic nerve. And so then we would be doing exercises to strengthen the serratus muscle, where I'm sure we're going to be doing exercises to stretch the chest out and to strengthen the back. And then she's currently undergoing chemotherapy. Remember, this is just hypothetical, but she could have been off it for a year or two and had a recurrence, and now she's currently undergoing. So what this means is that if she has vomiting or diarrhea, she's not going to work out for 24 to 36 hours. I actually had mentioned that she wasn't immunocompromised anymore when I first looked at the date, but now that she's undergoing chemo again, she actually would be immunocompromised. So if you're sick, you're not going to train her. She should wear gloves or wash her hands frequently, bring her own towel or exercise mat, don't drink out of a public water fountain. She may have peripheral neuropathy from the chemotherapy. If it's in her hands, avoid exercises that involve fine motor skills using her hands. If it's in her feet, avoid any high impact activities. Because of the chemotherapy, she is at a higher risk of damage to the heart and lungs, which we already know she needs to do cardio to lose weight, but she also needs to do it to strengthen her heart and lungs. She's also at a higher risk of diabetes from the chemotherapy. So if she does have peripheral neuropathy, which is also a side effect of diabetes, we need to make sure that she gets tested for diabetes if she hasn't been already. And then she's at risk for osteoporosis. She's already menopausal, so she's not producing any estrogen, and then the chemo will exacerbate that risk for osteoporosis. So we also know she needs to do a weight-bearing exercise program. She probably has very limited range of motion on that right side. We can compare it to the left side, which will give us an idea of what her norm is so that we can look at that compared to what we have in the book. And then we are going to start with what's most important. So what is most important to a 65-year-old overweight sedentary individual? First, we just got to get her moving, and we've got to get her doing something she enjoys, or she is not going to do it. She hasn't exercised her entire life, and she may not want to start now. On the other hand, she may use this as an opportunity to create a new lifestyle for herself with exercise and a healthy diet as part of it. So we want to make it fun. We want to make it effective, and we need to start and progress slowly. starting with cardio, very low intensity because she's undergoing treatment. I would only do, her whole session should be no more than 20 to 30 minutes, 3 to 4 times a week. And the cardiovascular portion should be at 20 to 40% of her Carvonin heart rate. We can gradually add on time as she can handle it, because even cardiovascular increases the flow of lymphatic fluid and can increase her risk of lymphedema. So we're going to start and progress both the resistance training and the cardiovascular slowly. So I think initially I'm only focused on the cardiovascular and the range of motion. And then as we get the range of motion to desirable norms, then we definitely want to start to add some strength training and work to prevent osteoporosis. So that is just basically what I'm looking for here in the case studies, that you can go through these, and I could go, there's more, and you can get into detail about what exercises you would do, what you wouldn't do, and why you wouldn't do it. And this is just a worksheet, or several of them, for you guys to work through on your own prior to working with cancer patients. And you're certainly welcome to scan those and send them back to us here. We can take a look and give you some feedback on those, because we certainly want to set you up for success in your new endeavor as a cancer exercise specialist. So let's wrap this up with our Module 4 Q&A. First question is, how long will it take to study and go through the coursework? And I believe I answered that at the very beginning and said that that is really up to you. While you have 180 days, some people will sit down all weekend long and get it done, and others will take longer. It really depends on how you retain information and how you learn. You need 80% on each of the 25 question exams to pass, and you will have 2 opportunities to take each test if you do not pass the first one. In the question, can I come and go from the exams? I don't believe so. So plan on finishing each of the 20 or each module. So you have to sit down with any given module and do all 25 questions. You don't have to do all 4 modules at once, however. And then how do you get listed on the directory? If you go back to the first slide, I asked you upon completion and passing to email at cetiguru@gmail.com your name, your email address, the phone you want listed, city, state, and zip, and then any credentials you would also like to see listed so people can find you. And we don't automatically list you, so we have to hear from you with the information that you want to appear on the directory. I so appreciate you watching this. Anytime, write us for help. Also, the phone number, which was on the first slide, or one of the first slides, was 503-502-6776. Watch your email in the next 24 hours to get access to this webinar replay and Q&A list. And good luck with your studies. Thank you for helping to empower cancer patients to take control of their lives and their bodies. Keep up the good work.